Thank you for your interest and for joining this webinar, which is about veterinary cardiology and its implementation in the everyday practice. I am Sebastian Tavrinir. I'm a European Business Development Manager for veterinary ultrasound at Mindray, and I will be the moderator for this webinar. Now, I would like to start with a short introduction about Mindray and the Mindray Vet Solution team. Of course, Professor Pascal Smets, and the format of this webinar. So I will begin if I can. So Mindray was founded in 1991 and is right now one of the leading global providers of medical devices and solutions, with over 10,000 professionals from over 30 countries, and we are servicing more than 190 countries. And Mindray has a mission to advance medical technologies and to make healthcare more accessible. And three pillars, or the three main product lines, are patient monitoring, life support, which has a worldwide third ranking, IVD, in vitro diagnostics, which has a worldwide third ranking in hematology, and medical imaging systems with a worldwide fifth ranking. So we can state with confidence that Mindray is a leading global healthcare provider. Now, since 2019, a fourth pillar was added, which is the veterinary pillar. And the origin of this pillar is based on the huge success of the human medical care business and is powered by the leading R&D capabilities of Mindray. So this means that in effect we have transferred the long experience, the organization, and the success stories and learnings of the human medical care business to the veterinary field. And this includes a new Mindray Vet Solutions team and veterinary product line, which is dedicated to bring better animal care, improve confidence and outcomes for animal caregivers and other innovators in the world. And we are centered around the slogan, "Animal care we do." And some of my colleagues, Heman and Hannah, are also present today on the webinar, so I'm happy to introduce them as well. And we have begun this webinar with showing our new video, which is also starring Professor Pascal Smets, who will be giving the webinar, which is about the mission of the Mindray Vet Solution team to protect animal well-being, and showing also the many people involved in the veterinary healthcare field, and from vet owners and trainers, R&D engineers, veterinary doctors and professors. So I hope you liked this video. And now, of course, I am honored to be able to present Professor Pascal Smets from Ghent University, which she's a specialist in veterinary cardiology, and she will be the lecturer for today's webinar. So, dear Pascal, thank you so much for joining us. We're very happy to have you here. So today's webinar, today's webinar will be about basic cardiology and how to perform it in small animal practice. And the webinar will take about 1 hour and a half. Professor Smets will start with the theoretical part, which will take about 45-50 minutes, which will be followed by a demonstration video with live commentary on the different views and measurements. And also for this video, we have worked with the new Mindray Vet S8, which is a dedicated high-end veterinary ultrasound system. And after this demonstration video, we will close with a short Q&A section, and we kindly ask you to fill in the poll at the very end of this webinar. So thanks again for joining us, and please enjoy this very interesting webinar. So Pascal, over to you.
Thank you, Sebastian, for the nice introduction. I'd like to welcome everybody. I don't know if I should say good morning, good afternoon, or good evening, because I understand this is a very international, or this may be a very international webinar. So I will just say welcome, everybody, and we will get started. So I will start with the theoretical parts. Okay. So like Sebastian said, I will talk today about basic cardiac ultrasound and how to apply it in small animal practice, mainly dogs and cats. And I want to start a bit by giving the background of this presentation. So in this presentation, I am focusing on the practical and technical aspect of echocardiography, but of course, this is just a small part of general cardiology in small animal patients. So the approach to cardiology patients, as you all know, of course, starts with the signalment, a thorough history and physical examination. And it's only after all of these things that we may go on to do an echocardiography. If you want to do a cardiac ultrasound, of course, you have to have a very good knowledge of cardiovascular pathophysiology to interpret your imaging findings. And I would also like to tell you that echocardiography is an advanced diagnostic tool. It is only to be used by a skilled person after extensive training. And the most extensive training that you can get is, of course, board certification, so a specialist diploma. But you can also reach a very good level by taking several advanced postgraduate courses. This webinar is, of course, limited in time, so it is by no means a complete echocardiography course. I want to stress this. I just picked out a few things, basic images, basic measurements, but it is not a complete course. So we will talk about the most important views and measurements. The other thing that I want to highlight is that, of course, you cannot learn echocardiography by following an online webinar. You need to do hands-on training under supervision. And if you want to know more about the theory behind cardiac ultrasound and the different views and measurements, there are many specific veterinary echocardiography textbooks on the market. So if you are interested in this and you want to work with your ultrasound machine, I would advise you to buy one of these books. Okay, so then we will get started. First, with the indications for echocardiography. So it's important that you do an echocardiography for the right reason. We don't do an echo in every cardiac patient, or we need to think about the specific indications for an echo. One of the most common indications is, of course, the detection of the cause of a heart murmur. Secondly, we use an echo in the diagnostic workup of patients with a very broad range of problems. For example, patients who faint, so transient loss of consciousness or syncope. Patients, for example, young puppies and kittens that have stunted growth, so that, for example, remain clearly smaller than their siblings. They may or may not have a heart murmur. Dogs with exercise intolerance, animals with cyanosis, also animals who have heart rhythm disturbances, so arrhythmias, to find a possible structural cause for these arrhythmias, and also to assess if this arrhythmia has an influence on the function or structure of the heart. So both ways, actually, to look for a cause, but also to look for the consequence of the arrhythmia. And then, of course, something that many of you will be confronted with in everyday practice is if you want to determine whether a certain effusion, whether it's pleural or abdominal, has a cardiac cause. And then, of course, cardiac causes in general cause modified transidates. Also, for example, chylothorax is an indication to look for a structural cardiac problem. As many of you will also be confronted with, echo is the best tool to diagnose and treat pericardial effusion. And also related to that, we will use echo to screen for cardiac masses, often neoplastic masses. And then it's also used, for example, in the workup of patients with fever of unknown origin. And that is when we are looking for valvular endocarditis, for example. Again, this is not an extensive list. It's just an example of the most common indications. And then also very often we will use echocardiography as a screening tool when we want to advise breeders, mainly for the detection of preclinical cardiomyopathy, and then especially for screening for dilated cardiomyopathy in dogs and hypertrophic cardiomyopathy in cats. So you see, there are many reasons to use your echocardiography machine. Now that we know how or when to use it, I want to go a little bit more into depth about the different modalities that are on the machine. So in general, there are 3 modalities to start with: the 2D or B mode. So this is this grayscale image, and with the grayscale image, we want to assess cardiac, valvular, and great vessel anatomy, and we look at the size of the heart chambers, the size of the vessels, the appearance of the valves, and also the subjective movement of both the heart muscle and also the cardiac valves. So this is the basis of everything. This is what we look at first. This is how we subjectively assess how the heart looks like, and it's also what we start with when we have a problem-oriented approach to our echocardiography. If there is an important abnormality in the 2D image, we will start from that main abnormality and try to find a cause for it. For example, if you see in your B mode that your left heart is volume overloaded, is enlarged, you will look for a cause for this type of enlargement. If you see that there is hypertrophy, so a thick muscle, for example, on the right side, you will look for a cause for that. So this is the start of everything. And this is also what you have to start with when you learn to do echocardiography. Secondly, there's M mode. M mode is a very important measuring tool. In M mode, we put a measuring line through the heart, and it will be through a particular structure, for example, the ventricle or a cardiac valve. And then the position of the structures that are on the path of the line will be shown over time. This means that M mode has a very good time resolution, and it can be used to measure wall thickness, for example, of the left ventricle, also diameter of the lumen. And you have the advantage that you can measure it at a certain time point in the cardiac cycle. So we can measure it at during systole and also during diastole. Especially, it's important that you put an ECG when you do an echocardiography, and then actually you can determine the exact time in the cardiac cycle based on the ECG. So it's used also for assessment of the myocardial movement and assessment of valvular movement. So these are actually 2 very important modalities. The last modality that I want to talk about is Doppler. And in the Doppler modality, we have 3 different types. We have spectral Doppler, color Doppler, and tissue Doppler. Spectral Doppler is what we use to measure blood flow velocity and what we use to do hemodynamic assessments. If you want to know what are the pressures in the heart, what is going on here hemodynamically, we use the spectral Doppler to calculate pressure gradients. Secondly, very important also is the color Doppler. The color Doppler will give you the direction of the bloodstream, will also allow you to detect turbulent blood flow due to valvular insufficiency, for example, or stenosis of certain valves or vessels, and will also allow you to detect cardiac shunts. One of the most important ones that come to my mind is, for example, a persistent ductus arteriosus in young animals. Then the last modality is tissue Doppler, and I'm not going to talk about tissue Doppler in this course because it is an advanced technique, but with this technique we assess the movement of the myocardium itself, so not the blood but the heart muscle actually. Okay, so now that we know the different modalities that are possible with our echocardiography machine, I will go a little bit more in depth on the different views, let's say different basic views that we will make. And of course, we start with the basis, with the B mode or the grayscale images. When you do an echography, it's really important that actually veterinary medicine, because our patients are challenging because they cannot tell us what is wrong, we have to follow a standardized approach to everything. When we do a physical exam, when we take a history, we follow certain steps in our head not to forget anything. And it's actually the same with an echocardiography. You have this standardized protocol that you follow with certain views and certain measurements that you will do. So this is important, that you learn a standardized way of performing an echocardiography and that you do it always in the same way, not to forget anything. So the 2D views can be generated from two positions of the animal. So you can place the animal on the right side, and from that side you can make the right parasternal images. Then the animal can also be placed on the left side, and the basic views that we make from the left side are the left apical views. So what we see here in the image below is actually the dog lying in position for the left apical images. So he's lying on his left side with the head here, and we are scanning from this side. When we want to do the right images, the dog is in another position with the head here lying on his right side. It's important for the image quality that you get good contact between your probe and the dog. So that means that in general, dogs with a thicker coat, we will shave. Then you it's always good that you put some medical alcohol or that you wet the coat so that there's no air getting in between the probe and the skin, and of course put a sufficient amount of ultrasound gel. Our little model for the video later is a little French bulldog. So this French bulldog has a very thin coat, so it was possible to scan it without shaving, with just wetting the coat and putting a lot of ultrasound gel. So that's a bit the practicalities. With this, I also want to give one remark. There are also colleagues who scan the dogs in a standing position. For that, you need a very trained assistant to hold the dogs correctly. And in general, most cardiologists will scan the dogs lying down. There are also a lot of advantages to that. Okay, now I would like to go on by explaining different images that we can side. So the starting view that we make is a little bit confusing, I admit, because this is actually the position of the hearts in the same orientation as the dog or cat is lying on your table. So the dog or cat is lying on the right side with the head here. This is the aorta. And here we can see the pulmonary artery. And this is the right aorta because it's lying on the right ventricle. Here we have the left ventricle, and here we have left atrium. And you see that what we want to do is actually we want to make a long axis image. So the axis of our probe is also directed in a longitude to the heart. Okay, so this is the first scanning position. We scan from the bottom, and then this is the image that we get on our screen. So actually it's flipped 180 degrees from the position here, because the atria are on this side. But this is basically the standard view that we do. So the atria are on this side. And then basically the image compared to the real live situation is also flipped upside down, because here is actually the location of our probe. Yeah, so it's actually flipped upside down and turned 180 degrees. So you have to practice this a little bit, that you get your head around the anatomy. Our probe is here, so the first thing that we will encounter is our right ventricle and our right atrium. Yeah, this is what we see here, right ventricle and right atrium. And then when we scan deeper, we will see our left atrium and our left ventricle. This is what we see here, the left atrium and the left ventricle. Here is the mitral valve, there is the tricuspid valve. Okay, this is a very important image, because you can get immediately a subjective assessment of what's wrong with the heart. This is, of course, a heart. The right left atrium, we see actually normal size of the heart and normal looking appearance. Okay. I've included some to give you a first impression about what's normal and abnormal. So here again, you see a similar image as before. This is a normal canine heart. And here we see a heart of a dog with severe mitral valve disease. So we see that the left side is very big. There is a volume overload of the left ventricle. We see a huge left atrium, so there's an enormous increase, but the move of the heart, despite the fact that it is so volume overloaded, the heart muscle is still moving quite well. It's trying to pump quite well. So this is also the difference, for example, between a dog with a mitral valve disease and a dog with dilated cardiomyopathy. The systolic function at first sight seems still quite okay. Okay, so this is just for you an illustration of an abnormal heart. Okay, then we go on to the second image, and for the second image from the right side, we turn our probe actually with our thumb away from us. So we're actually turning counterclockwise in this direction, just a little bit. What we want to do is we still want to get a long axis image, but we want to include the aorta. So we turn a little bit so we can, the base of the aorta is actually here, so it turns a little bit. So here is the base of the aorta. So we want to see this, and we want to get an idea of the left ventricular outflow tract and the aortic valve and the start of the aorta. So this is what we call a right parasternal 5-chamber long axis view. Why? Because we actually see left ventricle, oh, excuse me, I'll go back, left ventricle, right atrium. There's a little, you don't see it quite well, but there is some part of the left atrium still here, and then the aorta. In this image, and aortic valve, Then we go on to our next image, and for the next image, we actually want to make a different and now we are turning almost 90 degrees and turn counterclockwise, so that we are actually perpendicular to the heart, and that we are, you see that the axis longitudinal to 90 degree, the little mark of the probe is now facing towards us, and we have a short view. This is the right person short view at the level of the papillary muscles. So we see the left ventricle here, we see the papillary muscles, and we see a part of the right ventricle here. And then again, I present you one normal and one abnormal image of the right parasternal short axis at the level of the papillary muscles. I think everybody can see what is wrong with the heart here. See that, look at the size of the lumen. I mean, the lumen is just incredibly big, so we have a severe volume overload. We have the two papillary muscles here, and you can see that the heart is almost not contracting. You see a tiny bit of the right ventricle here. So this is a image of a severe dilated cardiomyopathy in a dog. And we move on to the next image. So the thing of making images for it is that we make all the images in a fluid movement. You don't actually move all. These are really small movements, because what we do is actually we continue a little bit our turn, but mainly what we are also going to start doing is actually lift our cable a little bit. Because if you see how we are actually dissecting or transecting the heart, we started making a line here where we are, this is the papillary muscle, where we are actually transecting the heart at the level of the papillary muscles. And what we want to do now is actually look at the mitral valve, and it's removed here, but the mitral valve in the model, in the model the mitral valve is removed, but actually it's lying here. So what you want to do is you don't want to look anymore in this direction with your probe, but you want to look in this direction. So you want to look a little bit more towards the head of the dog to make more a transection at the level of the mitral valve. And that is what we're going to do in the next short axis views. So we start here, papillary muscles, then we look a little bit more cranial towards the mitral valve, and then we will continue to look more cranial to make other views. So how does it look on the echo image? We have our left ventricle here. This is the lumen, and here we see the mitral valve. So it looks a bit like a fish mouth, okay? You can have a look at the mitral valve, see if it's thickened, for example, in dogs with mitral valve degeneration or bacterial endocarditis of the mitral valve. You could also put an M mode through it to see how the mitral valve is moving. Okay, so an image to have a look at the mitral valve. And then we continue our short axis views. And so we were looking in this direction towards the mitral valve. And what we want to do now is we want to get an assessment of the heart base. And one of the most important heart base images is the heart base image where we see the left atrium and the aorta. So we want to see this, we want to see the aortic valve, and we want to see the left atrium. So you see that we were first here, and now we need to look more towards the head of the dog to get here this sectional view, and also maybe lift our cable a tiny bit. And this is the view that we get. So here you see the aortic valve, and the aortic valve has 3 cusps. So we see the 3 cusps of the aortic valve. Normally we have a line here, here, and also here. And this is the left atrium, the body of the left atrium. And this is the left auricular appendage or the left auricle. Here we see a part of the right atrium. This is the tricuspid valve. And here we see the right ventricular outflow tract. This is right ventricle and right ventricular outflow tract wall. And here we see tiny bits of the pulmonary artery, or the valve of the pulmonary artery. So this is a very important image to try to assess the size of the left atrium, which we will compare with the size of the aorta. It's also sometimes a bit of a challenging image to make, also because here we have the pulmonary veins that enter the atrium, and sometimes it's really difficult to get a nice delineation here, which makes it also challenging to measure left atrium size. Here, I also present a normal and an abnormal image just for you to get the idea. So here we see our normal image from before, and this is a dog with a severe left atrial dilation. You see very clearly how big the body of the left atrium has become, and you also see some swelling here or some enlargement of the left auricle. In general, when we measure, let's say the size of the left atrium and we compare it to the aorta, the left atrial to aortic diameter in general is said to be has to be less than 1.5, but of course there's different reference ranges and different studies. But if you want to have in your head a general normal value, the left atrial to aortic ratio should be less than 1.5 or less to equal than 1.5. And then we're already arriving to our last image from the right side. And I told you before that this vessel is the pulmonary artery. And what we actually want to do is we want to have a look at the pulmonary artery, but we also want to try to measure the velocity in the pulmonary artery. And if you want to measure a velocity using spectral Doppler, you have to aim your probe so that you can measure as parallel as possible to the blood flow. This is really, really, really important. And it's something that everybody has to practice on a lot, because if you make an angle with the blood flow, you will underestimate the velocity. So for velocity measurements, we need to make images that are angled in a way, or that are optimized in a way that you can do a correct angulation of your Doppler measurement. So if you look here at our model, this is our pulmonary artery. So you actually want an image that's looking at it in this way. So you can measure actually the velocity of the blood that's going out. And this is the image that we get. So for this, what we will normally do is maybe lift our cable just a tiny bit, also look at angle the probe maybe a little bit more towards the head of the dog. So we were looking before in this direction, yeah, and now we want to look in that direction. And in some cases, you also need to move a little bit the probe towards the sternum. Again, I want to say the movements that I'm describing here are extremely subtle. Doing an echocardiography is nothing like doing an abdominal echocardiography. We are almost not moving the probe from one position to the other. You also see it when you look at the position of the hand here, right? It's minimal things that actually change. So the image that we get is this one with the aorta here. This is the right ventricular outflow tract. This is the pulmonary valve, and this here is the pulmonary artery. And then we try to angle our Doppler measurement so we get the maximal velocity. Okay. Then to end our images from the right side, I would like to show you an image of a normal pulmonary artery. So the pulmonary artery normally is approximately as big as the aorta, maybe just a little bit smaller. And here you see actually the pulmonary valves that actually look thin, and they look like they are moving normal. When you look at this image, I have to say that it's quite a little bit a subtle image, but I will try to show you anyway. So here we have the aorta, and here we have the pulmonic valves. And if you look very closely, you can see that this pulmonic valve here and here has an abnormal shape. They look a bit like this. So they look like they are glued together, and they are doming. They are a little bit pushed up like this. So this is a type of pulmonic stenosis where the two valve leaflets seem to be a little bit stuck. This is what we would call a type A pulmonic stenosis. Okay, if we measure the velocity across the pulmonic valve, then we would measure a severely increased velocity, because the valve leaflets are stuck together and the blood is not passing through. Okay, so that's basically it. Or there are, of course, a lot of or some additional images or non-standardized images that you can make when you are looking for several pathologies from the right side. But the images that we discussed so far are the standard images that we make from the right side. Now we turn our dog around with the head to the other side, so that he's lying on his left side, and we will discuss the left apical images. The left apical images are the scanning technique is completely different from the right side. When you scan a dog from the right side, your probe is actually, let's say, under the chest of the dog, and you are scanning quite, I'm not going to say completely perpendicular, but quite perpendicular actually to the chest of the dog. When we are scanning from the left side, it's different. If this is the chest of the dog, we are scanning actually really close to the sternum, and the angulation of the probe is actually almost parallel to the scanning table. So we are not scanning perpendicularly on the dog, but really high up towards the sternum and almost perpendicular to the table. And that makes sense if you look at the orientation of the heart. So the head of the dog is here, and the tail of the dog is there. He's lying on the left side. And what we are doing is we want to look at the heart from the apex. So it makes sense that if the dog is lying down, we are not scanning from here. Huh? We are not scanning from under the table or from high up the chest. We are scanning from the point of the heart, from the apex. So the view that you get, again, we are in a longitudinal direction. So the long axis of our probe actually transects the heart in a longitudinal way. The image that we get here is, again, upside down. Here is our probe. This is the probe. And what we see is the left ventricle and the left atrium. So here, left ventricle, left atrium. And then we see also part of the right side, the right ventricle, and the right atrium. This is our left apical four-chamber view. This is, again, a very important view that gives you an overview of the entire heart, where you can compare the chamber sizes, where you can look at the valves, where you can look at the cardiac movement. Okay. Here I have two examples of a normal left apical view and an abnormal left apical view, just for illustration. Here we see the left heart, left ventricle, left atrium, mitral valve. This is the right heart, right ventricle, right atrium, and then the tricuspid valve. And normally the right heart should actually be smaller than the left heart. And here you see that the opposite is true. And you clearly see that the right ventricle is bigger than the left ventricle. And it looks like it's an eccentric hypertrophy, so a volume overload of the left ventricle. And the same is true for the left atrium. So you see an increased size of volume overload of the right atrium. So this is a clear right heart volume overload. Okay. And then the second image that we are going to make from the left side is the left apical five-chamber view. So you see it's actually quite similar to the right side, where we have first our four-chamber view, and then we have our five-chamber view. And actually from the left side, it's the same. First the four-chamber view, and then we actually try to visualize the aorta. So here we see the aorta. Here below is the entrance of the aorta. So what we need to do, compared to our first image, is we need to turn our probe a little bit. And again, it's easy. When you are scanning from the left side, you actually have to turn your probe with your thumb away from you. So we are again actually turning counterclockwise. So the same direction actually as from the right side. So what you do is you do this movement, and then you lift the cable a little bit. Okay, so it's like this and like this. And then you try to visualize the aorta. And then what you see is this. So we have the left ventricle, left atrium, mitral valve. Here is the aorta, aortic valve, and there's here a little part of the right heart, right ventricle and right atrium. Okay, if these structures are not perfectly visualized, that's actually not a big problem. What we actually want to do with this view is we want to look here at the aorta. That's the most important thing here. What is very important is from this view, you can measure the velocity of the aorta, because you can get your spectral Doppler line actually very parallel to the blood flow in the aorta. So this is a view where you can measure aortic velocity. You can also put the color Doppler to look at the flow over the aorta. You can also assess the aortic valve. You can also look at the left ventricular outflow tracts. Okay, so a very important image. And this is basically it for the two basic images from the left side. There are other images that you can make more cranially. These are called the left cranial views, but that's a little bit more advanced, and I will not talk about it in this webinar. Another view that I have not mentioned here in the theoretical part is the subxiphoid or the subcostal view to measure the aortic velocity, but we will talk about that during the practical part. Okay, so this is the very basis of your echocardiography exam. These two images, you have to be able to make these views in a perfect way, and then you go on to applying the measurements. In a first measurement mode that I want to talk about, or modality that I want to talk about, is the M mode. So the M mode is a time motion mode. So what we will actually see is we will see the position, we put a line through the heart, and then we see the position of the structures on the path of the line displayed over time. So it has a good time resolution. And what we will do is we will use it to do measurements of wall thickness, also measurements of lumen diameter, and we can do it in both systole and diastole. What do you do then when you've measured these wall thicknesses and lumen? How will you interpret it? There are a lot of reference ranges or values that you can find in literature, especially in veterinary echocardiography books, for example. There are a lot of studies available that have made breed-specific reference ranges, especially in special breeds like, for example, bigger breeds or smaller breeds. So it is always good if there are breed-specific reference ranges that you use those. What you can also do is use normal values that are based on weights, and there are tables for that in books that you can find with several weights of dogs and then the normal values. What you can also do is you can use the normalized left ventricular diameter via the Cornell method. And then you need to put formula in the echo machine, and that will normalize your diameter. And then you don't need to take the weight of the dog anymore into account. So with the Cornell method, your normalized left ventricular diameter has to be smaller than 1.85, and your systolic diameter has to be smaller than 1.26. So that's also an option. What we can also do with that mode is we can measure the fractional shortening. That's a part of systolic function assessment. So how much is the heart actually shortening in diastole versus systole? And as I said before, we can look at the movement of the myocardium and the valves. So we will go more into depth about this in the practical parts, but mostly used for an M mode of the left ventricle is actually the short axis view at the level of the papillary muscles, where you have to make sure that your M mode line is perpendicular to the septum here and perpendicular to the free wall. So you are dissecting the heart exactly in two, and you are not making any, let's say, wrong dissections that are not orthogonal. Another possibility is to do an M mode in a right parasternal long axis. The difficulty here can be that you have the papillary muscle here and you cannot take that along into your measurement. The advantage of this method is that you can actually see exactly in the longitudinal plane where you are putting your cursor, because the M mode for the left ventricle basically has to be made in between the mitral valve and the papillary muscle, so at the level of the yeah, let's say the chordae. So here you can actually see, here is my valve and here is my papillary muscle, so you are directly in the right spots, but it can be sometimes a bit technically challenging. Then M-mode measurement. I will not go into detail too much because we can also discuss in the practical part, but it's always a good idea to put an ECG so that you know exactly at which part of the cardiac cycle that you are. So in systole or in diastole, and you can orient yourself on the ECG to do the measurements. So we will do measurements in diastole where we look at the septal thickness, so interventricular septum in diastole, then the lumen, left ventricular inner diameter in diastole, and then the free wall, left ventricular free wall in diastole. And then we do the same. So here is the T wave. So we are here between our T wave and the next P wave. So this means that we are here in systole. Here our heart is also contracting maximally. So we have the septum in systole, the lumen in systole, and the free wall in systole. And then if you have good near field resolution, because sometimes that's a bit blurred here, this image, but if you have a good resolution, you can also do a right ventricular measurement. You can measure the right ventricular inner diameter, for example, in diastole and in systole. The important point about this is where do you exactly place your cursor? And for this, we have what we call the leading edge to leading edge technique. So I've actually augmented the lines here, this line and this line, and you see that we actually start from the top of that line to the top of this line. So we are not on the line, we are also not under the line. We are from the leading edge, the top of the line, to the leading edge, again, the top of the line. On your ultrasound machines, these will be white lines. Again, here, a normal and abnormal image. So we have here a normal image, M-mode image in the short axis view of a normal dog. And this is the same image as our previous dog that we saw on the 2D short axis view. Here we have the M-mode cursor perpendicular to the septum in the free wall, actually dissecting the heart completely in two. And we see that this heart is almost not moving. And we see also that the diameters of the heart are absolutely huge. So again, as I said, reference values by weight and breed are available in books. There are several scientific papers with breed-specific values, and you can also use the normalized diameter. And then we're almost finished. I will go over the last modality, and that's the Doppler modality. Just a brief introduction. So there's, I said there's three types of color Doppler, three types of Doppler. We will talk about spectral Doppler and color Doppler. Spectral Doppler is the modality that we use to measure blood velocities. So this is our probe, and we have our red blood cells that are moving, and either they are coming towards us, and then we get a flow signal above our baseline, or they are moving away from us, and then we get our signal below the baseline. Color Doppler is similar. So normally the BART flow chart is being used. So blue towards, red towards and blue away, red towards. So that means that the red color is blood flow that is coming towards us, and the blue color is blood flow that is going away from us. So these are the standard settings. Here again, you see the color Doppler. So that's what I meant with the BART map, blue away, red towards. That's the normal setting. And then you can use different settings to indicate turbulent flow. A setting that is often used is the variance setting, where you add green and where the turbulent flow is actually in green. So here we have a left apical view Here is the color Doppler. The flow is coming towards us. So this is the blood that is coming out of the left atrium towards the left ventricle. This is blue. Here we have the blood that is going away out of the left ventricle, away from the probe in the aorta. Our probe is always here. So this is coming towards and this is going away. As an illustration, we see here in normal dog, there is actually only normal red and blue, and we don't see any turbulent flow. This is a still image of a dog with a severe mitral regurgitation, where we see the turbulent blood flow actually, the mitral insufficiency actually moving in this direction. It's actually going between, against the wall of the left atrium and then bending and going against the interatrial septum. So this is a severe valvular insufficiency. Okay. Then we are left with the pulsed wave and the continuous wave Doppler. So the pulsed wave Doppler allows us to measure blood velocity and blood direction. And the thing about pulsed wave Doppler is that it has a range resolution and it will measure at a certain position. So the cursor is a line and it has a little sample volume or a gate. And this is the location at which the pulsed wave will measure the blood velocity. So you're basically measuring velocity at a certain point in the heart. The pulsed wave Doppler can give you also the distinction between laminar and turbulent flow. The disadvantage of pulsed wave Doppler is that it cannot measure high velocities, okay? So usually, let's say, most settings about 2 meters, a little bit more than 2 meters per second it will measure, but it cannot measure high velocities. The pulsed wave Doppler principle is mentioned again here. So this is our left apical 5-chamber view. This is our aorta. We have our sample volume. And normally we would actually put our sample volume, let's say here at the level of the valve, and then we get aortic flow. When it's nice and laminar, we get uniform velocities and we get a hollow flow profile that actually looks a bit black in the middle. When there's turbulent flow, we get variable velocities and our pulsed wave signal will not be hollow anymore. With this, I have to say that if your pulsed wave Doppler is not positioned perfectly in the middle of the vessel and you are a little bit more against the wall, for example, you will also get this result. So it's important to understand that it's not because you don't have the perfect velocity profile that looks hollow that it's immediately pathologic. It can also be a little bit of artifact. So it doesn't immediately mean, this does not immediately mean that there is a severe pathology in the vessel. Here you see an example. So this is the sample gate that's positioned at the level of the aortic valve, and you see the aortic velocities, nice, laminar, and hollow. The little stripe that you see here is actually the closure of the aortic valve. Last one, the continuous wave Doppler. So the blood flow velocity and direction are measured over the entire cursor line. So we don't have our specific location where we're measuring. This means that continuous wave Doppler will not distinguish between laminar and turbulent flow, but this is the Doppler that we will use to measure high velocities. There is no range resolution, so we can measure high velocities, for example, mitral valve insufficiency with a velocity of 5 meters per second, or an aortic stenosis with 6 or 7 meters per second. We can measure this with the continuous wave Doppler. So again, here we see our left apical 5-chamber view with our continuous wave Doppler nicely aligned parallel with the blood flow. And then we get these profiles, and the profiles of the continuous wave Doppler, they are full, so they are not hollow. This is an example of the measurement of the aortic velocity. In normal situations, it will be approximately less than 2 meters per second. So you can measure from the left apical 5-chamber view, and you can also measure from the subxiphoid or subcostal view. We will see that in the video. Pulmonic velocity is, of course, measured from the right parasternal short axis view at the level of the pulmonic artery, as we said. So we try to get it as parallel as possible in the pulmonic artery. And this dog had a tiny bit of pulmonic insufficiency, so we had some blood coming towards us here, and this is the blood that's going away. In general, pulmonic velocity is less than 1.7. The normal values differ a little bit across different studies. In general, we will not be worried as long as it's below 2 meters per second. Last one that we will also do is the mitral inflow profile, and that will give you an assessment of diastolic function. Assessment of diastolic function is quite challenging, so I'm not going to go into that in this webinar. But one of the parameters that is quite easy to measure is the mitral inflow. That's the velocity of the blood that is coming from the left atrium into the left ventricle. So we will do this with the pulsed wave Doppler because we want to measure at a certain point. And that's actually the point. I should have probably taken an image where the mitral valve is open. So when the mitral valve is open, it's actually the point where the two valves are ending, or the two valve leaflets are ending. So this is the point where you want to measure. And you see here that you have two peaks, the E peak and the A peak, early diastole, the early filling, passive filling. Then you see here you have your P wave, and after the P wave you have the active phase of the filling, so the active contraction of the atria that will also send part of the blood or the remaining part of the blood into the left ventricle. Okay, this is important when you want to, for example, assess pressures in the left atrium. It will give you prognostic information in dogs with mitral valve disease, for example, and it will help you to diagnose different cardiomyopathies in cats. Okay, so I am talking a little bit longer than was foreseen, because I always get very enthusiastic when I'm talking about echocardiography, but I will round it up here so you don't have to listen too much to the theory anymore. So I would like to end by putting this all a little bit together. So when you do an echocardiography, you start with your 4-chamber view from the right, and you make an overall assessment of the chamber size, of how the heart is moving, of how the valves look. And then you try to use a problem-oriented approach. I could probably also talk for an hour about problem-oriented echo. I don't have the time to do this, so I will just give an example. If you look at your 4-chamber view and you see these huge left hearts, in, for example, a Cavalier King Charles puppy that you've auscultated, and the dog has a left systolic, left apical murmur, 4 out of 6, and you see a big left ventricle and a big left atrium, of course, and the mitral valve looks a bit thickened. This is what you will be investigating. You will be investigating your left-sided volume overload. Okay. If you see concentric hypertrophy of the right ventricle in a young puppy, for example, a boxer puppy, then you will be looking for causes of right ventricular concentric hypertrophy, for example, pulmonic stenosis. Okay, so you will think about it while you're doing the echo and follow the abnormality that you see first will guide the rest of your exam. Then you will perform the 2D M-mode and Doppler measurements that we will talk about more in the practical part. Identify the abnormalities using reference values. Where possible, you base it on breed, and you base it, otherwise you base it on weight. Then with all of this information, you form your final, your complete diagnosis, and then you go back to your patient. Does my echocardiographic diagnosis fit the clinical signs of these patients, the abnormal findings that I have on auscultation or on physical examination? Okay, so you always integrate everything together: history, signalment history, physical exam, complete echo exam to make your final diagnosis. And then last point, this all seems fun and nice, but how do you learn to do it yourself? The best advice that I can give you is practice makes perfect. And for echocardiography, you need a lot of practice. Don't be too hard on yourself. It takes time to become a good echocardiographer. You can only learn this when you follow qualitative hands-on training courses, and you need experienced people to guide you and to correct you hands-on. start with dogs that lie still. Don't start with cats. Learn how to get perfect B mode images from the right and from the left, and then apply your measurements. Move on to cats when you are capable of doing a good dog echocardiography, and refer in the beginning when you start practicing more small animal cardiology, refer your patients to a cardiology specialist so you can learn from them what they say, what they have found on their echo. So with that, I would like to conclude the theoretical part, and already like to thank you for your attention.
Perfect. Thank you, Pascal. It was very interesting. So now as you said, we're moving over to the practical part, the demonstration video, which Pascal will play. Thanks again. It was very interesting, Pascal.
You're welcome. Okay, can everybody see the screen? I think so. Okay. So here with this video, what we actually try to do is we try to film actually a live complete echocardiography exam. So you see here that the dog is lying in right lateral recumbency. I've wetted the skin of the dog. It's a little French bully with short hair, so I didn't need to shave. And then you saw me putting a lot of gel. That's always a good tip for people who start with echocardiography. Use a lot of gel. And we are starting with the first image from the right side. So what you can see here is the left heart, left atrium, left ventricle, mitral valve, right atrium, right ventricle, and the tricuspid valve. You see that I've also put the ECG below, so that we can actually know in which cardiac cycle that we are at the moment. Yeah, maybe one more thing that I would like to say about this image. So we'll go maybe back just a little bit. Yeah, here, for example, if we pause it. So what we basically assess in this image is the chamber size, where the left atrium normally is bigger than the right atrium. We look at the anatomy of the valves. We also check the size of the right and the left ventricle. As you see, the right ventricle should be smaller than the left ventricle, and also the movement of the heart. Anatomy of the valves, and also the interatrial septum that you can see here. Okay, then what you can do in this image is you can assess the cardiac valves using color Doppler. I have to say, Doppler, as I said, always works best when you are parallel to the blood flow, and this is less so for color Doppler than for pulse wave and continuous wave Doppler. You see, I am actually scanning from here, so I am perpendicular to the bloodstream, and you will see color Doppler. But it helps to also have a look at the valves from the left apical view, because sometimes there will be some insufficiencies that you don't, small insufficiencies that you don't see in this view, and then you can check again on the left apical view. Here we see sometimes a very tiny, yeah, here it was a very tiny mild tricuspid insufficiency. Was the blue-yellow jets that you could see here. Here in the color Doppler, we don't see the green, so I did not put the variance on here in this image. So if we have an insufficiency, it will actually look bright blue yellow, okay? And you see me also recording images, and that's also something that I can advise you. Record loops of the 2D images that you make, so you can do your 2D images offline. So I record loops of the 4-chamber long axis view. Then I do the color Doppler on the valves. I also record loops of the color Doppler, so that you can review them afterwards. What I'm doing now is basically I am putting an M mode line through the long axis image. I'm trying to aim it so that it is between the mitral valve and the papillary muscle, but you can see already the challenge. Here you see, sometimes you see the papillary muscle coming into the image. You can also see sometimes the chordae coming into the image. That is what you see here. But if you have a couple of good cycles, then you can do a measurement. I have to say that I made this exam a little bit challenging because I took a little French bully as a model, and she's completely sweet and nice, but when she lies down for an echo exam, she starts to snore, of course, and her respiration is quite pronounced. So you see the heart actually moving quite a lot with the respiration, and that is also a problem that you will be facing in practice, that sometimes when you're doing measurements and when you have dogs, for example, brachycephalic dogs that breathe quite deeply, you will see the heart moving, and that also causes these movements that you saw on the previous image. Now we're on to the 5-chamber view. So we see the aorta here in the middle. This is the aortic valve. You see, our little doggy is moving. I will maybe just go back briefly so I can show you again. Yeah, here maybe, yeah. So this is the left ventricle. Here we have the aortic valve, and here we have the aortic arch, little part of the left atrium here, and then we have a part of the right atrium and the right ventricle here. And then what you can do is you can do a 2D assessment. How does the valve look? How does the left ventricular outflow tract look? And you can put a color Doppler here on the aorta. If you would have a dog with a heart-based mass, for example, a chemodectoma, which would not be impossible in our little model here because it's a French bully, she's not old enough yet, you can see, you would see a mass sometimes here in this location when it's a heart-based tumor. So that's a good location to look for that as well, okay? So then we go on to our short axis view at the level of the papillary muscles. So you see again, she's moving and breathing. So here is the papillary muscles here and here, the lumen of the left ventricle, and then here above we see the right ventricle. And every now and then I tilt my probe a little bit like this, and you can see actually the mitral valve coming into view. And that helps a little bit to decide, so looking at the mitral valve and then tilting a little bit back, that will help you to decide where to put your M-mode cursor, because you want to be in between the papillary muscle and the mitral valve. So there it is, the M-mode cursor. So you see, I'm actually not moving at all myself. My hand is completely still, and you see how this heart sometimes moves a little bit with the breathing. It moves actually in and out of the image, or as opposed to the line. But we have stored the images, and we have several good cycles that we can measure. Okay, then we're on to the next view, which is the short axis view at the level of the mitral valve. You saw the little fish mouth here. Yeah, and there we can also put an M-mode line. Maybe I will freeze that image. So what you see here in the M-mode at the level of the mitral valve is the movement of the mitral valve. And it's similar to the mitral inflow profile, because you have two phases in diastole. You see the first phase, the first movement, which actually is the same or in timing as the E wave that we see on our mitral inflow profile. And then here we see the A wave, or the movement during the active filling, and that's actually behind or after the P wave. So in two phases, the mitral valve will move. When your cardiac cycle is shorter, like here and here, the two peaks will be closer together, like here. And when the cardiac cycle is long, this dog has a respiratory sinus arrhythmia, the two peaks are actually more separated. You see here they are very separated. Okay. Good. Okay, now we're on to the heart base image. where we see in the middle the aorta, and then the left atrium and the left auricle. Our dog is moving a little bit more. Aorta, left atrium, auricle, right atrium, tricuspid valve, right ventricular outflow tract, and then it goes into the pulmonary artery. So what I'm doing here is I'm storing loops for the measurements afterwards, because you never know how still your patient will lie. So it's always a good idea to store the loops. You have also people that freeze the loop and then measure. I don't like that. I just store them and continue with my echo exam and then measure afterwards. You can also check several valves here. Huh? So I put the color Doppler on the aorta first, and then you can also put it on the tricuspid valve to look for valvular insufficiencies. See if I have any more. Yeah, so now what I'm trying to do here, but our little model doesn't agree with me and does not completely lie still. What I'm trying to do here is put the color sector on the tricuspid valve to get an idea about tricuspid valve insufficiency. There is a small one. I'm not sure if we will be able to visualize it here, but we will visualize it from the other side. And then we move on to our pulmonary artery. And so this is our pulmonary artery, the pulmonic valve. And then we saw in the previous image, maybe I can go back just a tiny bit if I can freeze it. So there was our tricuspids. Yeah, so here below we saw just briefly the bifurcation of the pulmonary artery in the right and the left branch. Here we put our color Doppler on the pulmonary artery. We see the blood flow in blue going away from our probe, and then we see this tiny orange flame coming towards us. And that's a tiny small pulmonic insufficiency, and that's actually physiologic. When it's this small, you can see it in a lot of normal dogs. So it's nothing to worry about. It's just nice that the machine is showing us this tiny insufficiency, but it doesn't have any clinical relevance. Okay, so here again, you saw a little bit of the bifurcation. And then the last thing what we can do from this side is actually measure the pulmonary velocity. So this is our pulsed wave Doppler. This is our sample gate. So what we try to do is we put the sample gate approximately over the pulmonic valve. And here we see our pulmonic velocity. The dog was moving quite a lot, so we see the heart also moving. So it's a real life situation like you will have in practice. So what you always try to do is you try to get the best alignment possible. You can actually move between the pulse wave Doppler and the 2D image to reorient your pulse wave Doppler cursor. Okay. Good. Then we will move on to the subcostal image or the subxiphoid image. I'll just freeze here for a second. So our dog is still lying on the right side. The head is here. This is the chest. And here we are actually below the xiphoid, so in the liver region. And what you actually do is you shave or you put some alcohol on this region, so right below the xiphoid. And then with your ultrasound probe, you just put some gentle pressure first downwards, and then you angle your probe towards the head of the dog. So you cannot see it because my hand is blocking the site, but the probe is actually angled almost parallel with the dog in this direction. So I'm really angulating underneath the xiphoid towards the head of the dog to try to get a parallel angulation with the aorta that is running in this direction. So this is, so here you see the diaphragm, and we have to, of course, I put a little bit extra gel. You have to, of course, adjust the depth because we are at a very deep here because we are looking through the liver and through the diaphragm to the heart. So what you see here is actually the left ventricle. This is the aortic valve. This is the aorta. This is a part of the right atrium. And here you see the left atrium, and the mitral valve. So what you actually try to do is you try to angle your continuous wave Doppler as parallel as possible to the aorta. And here you see this different shape. This is not an actual sample gate. This is the continuous wave Doppler, and the continuous wave Doppler is actually measuring the velocity across all of the line. So it's a continuous wave Doppler measurement because, of course, we try to measure high velocities and we are very deep. So then it's easier to use the continuous wave. Okay, so that was an illustration of the subxiphoid measurement. Why do we use this? That's because in normal circumstances, you can get more parallel to the aortic flow when you are using the subxiphoid view. So the angulation will be still a little bit better than the angulation from the left side. And it's something that is important when you are measuring dogs, for example, with subvalvular aortic stenosis, and also, of course, in breed screening, when you are screening, for example, a boxer dog, you want to get the absolute maximal aortic velocity, and then it's best to do a subcostal view. Yes, okay. Now we move on to the left side. So we turned our little dog. We see here the head, and she is lying now on the left side. We are scanning in a completely different orientation. So from the apex with our probe really parallel to the dog and very close, almost on the sternum. And here we're actually optimizing the images a little bit. There is several functions on the machine to do that. So you see here a very nice left apical view, really nice ECG. And this is again an image that allows you to do a very good general assessment of the different cardiac chambers and structures. So we will again record a 2D loop, so actually a video, so that you can do 2D measurements afterwards. Okay, what I'm explaining here is the orientation of the probe. So we are scanning actually from here, from the apex. Here is our probe, and we are looking towards the atria who are here. Okay, so left apical four-chamber view. And as I said before, we can also do a color Doppler on the mitral valve in this direction. And you saw here a little, here in the middle, there's a mild mitral valve insufficiency that we didn't see on the other side. It's very small. It's also clinically irrelevant. But it's easier to see it from this side because we're nice parallel to the blood flow. Secondly, what I also still want to say is when you are doing a color Doppler, you have to take care that you don't put your gain too high. So you can, if you turn the gain on your color Doppler and you turn it really high, every insufficiency will look like a huge insufficiency. So that's not something that you should do. You should not put the gain up too high. What I'm trying to do here is see if I can measure this tiny insufficiency. We see a little bit of flow here. This is, again, the continuous wave Doppler, because what we want to measure is a high velocity. Mitral valve insufficiencies have velocities around 5 meters per second. And you saw it just briefly. That's because it's so small. This is then the pulsed wave Doppler. You see here the open gates, the sample size that is actually positioned at the tips of the mitral valve. Maybe I'll just go back for a second to show you the position. Yeah. So you see, yeah, it's here. It's a bit too high, but the valve is already closing. What you shouldn't do is you shouldn't put it here. You should actually put it at the level of the tips of the mitral valve when they are open, so around here. So not under the mitral valve, not too high in the ventricle at this point. So here you see our mitral inflow profile, E and A, E and A, E and A. So nice mitral inflow profile, completely normal. Also the velocities, we want them to be clearly yeah, below 1. So that looks good. Okay, let's see if I can move on. Yeah, so now we are moving on to the left apical 5-chamber view. We have our aorta here, and this is again the continuous wave Doppler. And what I'm doing is I'm putting the continuous wave Doppler in the aorta. When your dog is moving, you can move from your 2D image to your color Doppler, to your continuous wave Doppler image to correct the angle of your cursor. This is then the color Doppler on the aortic valve. So we don't actually see significant insufficiencies or turbulent flow. We also didn't expect it because the dog has no heart murmur. And then the last thing that we do from the left is actually we try to focus a little bit more on the right heart. So sometimes this means that you have to move an intercostal space, one intercostal space more cranial with your probe. So that's what I'm doing now. I'm actually moving the dog backwards. So I can put my probe, instead of being completely apical and on the sternum, I'm still quite apical and on the sternum, but I'm actually moving one intercostal space more cranial. And this is, again, you can see every now and then a bright blue jet going in this direction, and there's also one that's sometimes going a little bit in this direction. So here, that is the tricuspid valve insufficiency. So it's a mild tricuspid valve insufficiency. For this dog, it also doesn't have any clinical consequences. And what I'm doing here is I'm actually putting the continuous wave Doppler through the insufficiency, and then here you see a little bit faint the envelope of the velocity of the tricuspid insufficiency, but it's a mild insufficiency, so it's not really relevant. Okay, that's it for the images. So what we will do now is I will show you some of the measurements. So I start usually with the measurements from the right side, a bit the same order as the order in which we perform the echo. And one of the 2D images that you can do on your right parasternal 4-chamber view is a volumetric measurement to look at the volume of the left ventricle. This is not an easy measurement. I do this now because I have my fixed order, and I start with this and then I move on to the next measurements. But if you're a beginning echocardiographer, I would advise you to just start with the M-mode images. You have to make very good long axis views if you want to correctly measure the volume, because what you actually need is you need a good delineation of the apex. So you cannot cut off the apex, because if you do that, then your measurement will not be correct, because you see here that the length of the ventricle is a very important part of the calculation of the volume. So if you are not satisfied with your 4-chamber view, if you think it's too short, or if you have cut off the apex, then please don't do this, okay? It will not help you. You will get underestimations and you will make wrong decisions. So do this when you are already at a more advanced level, when you are confident already, when you've taken several courses, when you can make really nice long axis 4-chamber views, then it's a measurement that you can do. So the first thing that you saw is that I was actually tracing the endocardium in diastole. So the previous image was the image in diastole. Now I froze the image in systole. I start by tracing at the level of the mitral valve annulus. I trace the endocardium, and then here we have always a little bit of a difficult point. That's the point where we see the papillary muscle. We cut out the papillary muscle and we end here at the mitral valve annulus again. So there's basically 3 points that are very important. Point 1, don't go too far, don't go actually beyond the mitral valve annulus. So you orient here on the mitral valve annulus. Second point, you need a long ventricle. Third point, you need good delineation of your endocardium. And with that, I also mean that in systole, you will have to probably cut out the papillary muscle. Okay, so that is the left ventricular volume in diastole and systole, and the method that we use is the Simpson's method of discs. So what you see here actually is, I will maybe explain it just briefly before we go on to the M-mode image, is that the machine actually divides the left ventricular cavity in several discs, and the machine makes a summation of all of these discs and calculates the volume based on that. So it's in your machine, it is also marked under Simpson measurements. Okay. So already a little bit more of an advanced measurement to start with. Most people, when you start, you will start with the M-mode image here in the short axis view. So what we want to measure is actually the wall thickness and the diameters. Often it is a bit challenging to have a good resolution here of the right ventricle. So I don't standardly measure the right ventricle in this view. Usually I focus on the left ventricle. It's of course different when you have dogs with a right-sided problem, then of course we will do it. But I advise you to start with the left ventricular measurements from this side. So you orient on the ECG for diastole, and you put your cursor above the white line here also. You end the measurement above this bright white line, then you go down to the left ventricular free wall, you end above the white line, and you go down again, and here you also end above the white line. So we have a measurement of the interventricular septum in diastole, the lumen of the left ventricle in diastole, and the free wall in diastole. Next is, after the T wave, we are here in systole. This is the thickness of the septum in systole, the lumen of the left ventricular of the left ventricle in systole, and then the thickness of the free wall in systole. Because this is what you actually see when you put your line. The first thing you see is right ventricular free wall, then you see the lumen of the right ventricle, then you see the interventricular septum, the lumen of the left, and the free wall. So this is how you dissect your heart, and this is then how you see these structures set out over time. Okay. Yeah, maybe one additional thing that I wanted to explain. So then here you see the different measurements, and your machine will automatically also calculate the fractional shortening in percentage, which is here actually perfectly normal for a healthy dog. It's one of the parameters that you can use to assess systolic function. When you measure a volume, that is something that I didn't explain before. You will, the machine will also calculate an ejection fraction, which is then also a measurement of systolic function. So you use all of them together to get an idea of the systolic function. But assessment of systolic and diastolic function is again a different webinar, let's say. Okay, then what I'm doing here is I'm actually measuring left atrial size, and that can be a bit challenging to find a good view, a good cycle where you can get a good delineation of the atrium, where you don't have too many disturbance of the pulmonary vein coming in here, and where you get a good view of the aorta. So I'm actually looking for a good place to measure. This is not super because it's a bit unclear here, but okay. It's a real life situation, so we will have to do it with that. So basically what you are doing is we are measuring the inner diameter of the aorta, and you cannot really see it really good in this image, but what you actually do is you follow the line between the aortic cusps, and it's between the non-coronary and the right coronary cusp that you are actually following the line. But I've watched, of course, the 2D image, and I know from the 2D image where the line between the cusps is running. So we orient on this line between the cusps, and then we start internal diameter of the aorta, and then we follow this line for the left atrium, and we measure the internal diameter of the left atrium. There's a lot of debate on this. You see here it's not clearly delineated, and you should probably not measure all the way up here. You should also probably not measure all the way up here. It's probably around this. It's not a problem for this dog because this dog is obviously completely normal, and I have an LAAO of 1.3. So this is not an easy measurement. And for this reason, we will also measure the left atrium from some different views. Here I'm explaining again that the delineation here is not perfect. Okay. Let's move on. So this is the pulmonary artery velocity measurement. Here you see the pulmonic valve. This is the bifurcation, the right mean pulmonary artery and the left mean pulmonary artery. And this is our pulsed wave measurement. So you go to pulmonic valve, and there you see pulmonic velocity, V max, and you can measure the velocity. Important for this is that you don't measure all the way until the end of the little feathery edges, but that's, wait, I will just go back for a second, that you measure actually where your signal is delineated best, and you don't, if you have these feathery edges here, these profiles are not very good, but sometimes you have still some edges here, you don't measure all the way down, you measure where you have a good delineated signal. Okay. Yeah, this is actually what I was talking about. So you can measure the left atrial size compared to the aorta in the short axis view, but what you can also do is measure a long axis atrial diameter. And for that, we go back to our right parasternal 4-chamber view, and you see here the mitral valve annulus, and you try to draw a line through this. And then you actually try to stay perpendicular to this imaginary line through the mitral valve annulus. And then you basically orient yourself and you measure from the interatrial septum, which is here, to the free wall of the atrium, which is here. And then you have the left atrial diameter in systole. Okay, so we are here. This is our T wave. We are in between the T wave and the next P wave. So we are in the beginning of systole. Sorry, at the end of systole, when the atrium is actually biggest. What I want to say here is that this measurement is particularly useful in cats. When you want to assess left atrial size, when you want to decide on whether a cat has dyspnea from cardiac origin or from respiratory origin, it's always a good idea to do this measurement, because it's often, when you begin to do cardiac ultrasound, more reproducible and easier to measure than the LAAO. And the cutoff actually for normal left atrial size in cats is approximately 16.5 millimeters, okay? This dog, of course, this is a dog, so it's allowed that this dog has a bigger left atrial size. Okay. I think that's it from the right side, indeed. What I'm doing here is basically I moved on to the 2D loop that I've stored from my left apical 4-chamber view, and I'm going again to the volumetric measurement. So I'm actually here choosing the Simpson method. I am here oriented in diastole. So maybe again, I will go back to show you how, I don't know if it's on the video exactly, how to choose the right moment for the measurement of the volume. Here I'm scrolling to the stored images. Ah, yeah. So normally what we actually do is you scroll, there you see it. So there the mitral valve is open, and then I scroll a little bit further, and I take actually the first frame after the closure of the mitral valve. And then again, the technique is the same as from the right. So you start at the mitral valve annulus. You try to trace the endocardium as good as you can. And here is the tricky part. Probably here I am a little bit too high up. Might be that I would have to go a little bit more here. The delineation of the apex is actually the tricky part. And the second thing, the same as from the right side, is getting a long left ventricle, because again, the long axis is really important. So again, this is a measurement that you do when you are really confident with making good left apical images. And here, you saw again how I choose the moment to measure the systole. So we are here behind the T wave, but I actually chose the moment again right after right before the opening, the closure of the valve. Wait, I will try to go back. Okay, here we are in diastolic. Select and you try to you pay attention that you trace it really nicely, and the difficult part is to good. It again allows you to do this when you are very skilled already in basic echocardiography. Okay, so here you see that the machine will calculate the stroke volume and will also calculate the ejection fraction, which is also a parameter for systolic function. And then we are moving on to the Doppler measurements from the left side. So here we have our mitral mitral inflow profile with the post-wave Doppler positioned here at the tips of the open mitral valves. To go to mitral valve, you see here mitral valve E velocity, mitral valve A velocity, and this is the beginning of diastole, the early filling phase. So we have our E peak. So here we put our measurement for our mitral valve E velocity. Bigger than the A peak, but I'm not going to go into detail because that leads us to a discussion of the assessment of diastolic function, which is not the aim of this webinar. And then from the left side, the last Doppler measurement that we can do is the continuous wave Doppler measurement of the aortic velocity. We see here we are in a 5 chamber image view with the color Doppler, with the continuous wave Doppler here. And again, we measure here our velocity profile. And here we have a completely normal aortic velocity of approximately 0.75 meters per second, so well below the 2 meters per second. Same thing we can do in our subcostal view. This is the subcostal view, or the subxiphoid view with a continuous wave Doppler. And again, we measure here. Here we have a velocity of 1 meter per second approximately. So we have a velocity that is a little bit higher than the velocity that we had from the left apical view. But in this case, not in a way that it would affect our decision about is this an aortic stenosis, yes or no. But if you are screening dogs for subvalvular aortic stenosis and you want to get the maximal velocity, then you should use the subxiphoid view. Okay, that was it for the practical part. I hope it clarified the theoretical part and that everything was clear. And then I would like to end this by thanking my, I need to thank my, my helpers and my model. So let's see, here they come. You see, we had a lot of fun doing this video. I'm talking, making jokes. Here they are. So this is my colleague Arnaud. He's one of my PhD students and he was the assistant holding the dog. And this is little Zina. She's our nice model and she did snore every now and then, but she almost didn't move. So she did a great job. And for that, I would like to thank my resident who lent her dog to be a model for this video. So thanks to them and thanks to you for your attention. And we'll go on to the questions.
Perfect. Thank you. Thanks a lot, Pascal. It was very interesting, very well brought. A pleasure as always. And so very, very thankful.